So, seeing as Mark is the last one up, I'm going to have to punish him. There's a few questions about billing for nitrous oxide and for remifentanil. Can you tell us how you get money for your services?
Sure. It's actually not a completely simple question because there's a little debate about how you should be billing for it. UCSF, I believe, Stanford also, you bill a base rate plus 5, and you can email me for the exact codes for it. And then there are institutions which don't bill because the epidural rate following nitrous is so high, they just find it easier to not bill.
So what we did at my former place where we used nitrous oxide is that we just offered it. We billed for like $50 or so, and some insurance companies will pay for it, and we used a code that Dr. Rollins would use, and some they just didn't. It really, the price of the nitrous oxide machine is not that expensive. Like if you think of the institutionalized, maybe $5,000, $7,000 or something. So we basically rolled that price into the whole delivery. Your expenses, at least for us, it came from using the hose and the mask, and that was about $20 if you bought it through a supplier. The nitrous and those E-tanks and the oxygen tanks, that pretty much just came from respiratory, and it wasn't a problem. So it really minor in a whole scheme of things, it's not that big of a deal for charging.
So a question for Dr. Riley, with your PIE technique, how do you handle walking epidurals? Because you're getting an intermittent bolus periodically. And how do you handle an emergency section? Do you alter your top-ups if you're using the technique versus not?
What was the second part of the question?
They may have just received the bolus from the PIB or not when you're topping it up for a C-section.
Oh, well, first of all, for the walking epidural, we lost that battle a long time ago. We don't really use the walking epidural. We use the technique is basically what the walking epidural is, which light local anesthetics. But our nurses didn't feel comfortable with the patients walking, even to the bathroom. And so we really haven't allowed patients to walk. In terms of just theoretically speaking, I don't think it would be that much worse to have them walk with a PIB pump versus with a continuous pump. It's probably, hopefully it'll be more motor sparing with the PIB pump, so they should be able to walk better, but we don't do it. Second, in terms of like if they just received a PIB bolus and then it's time to go back for a section, again, what I was really emphasizing, you're only talking like 6 milligrams of epidural bupivacaine that they got. It's not significant in terms of what you're going to be giving them for their C-section, so it's not something to worry about.
Yeah.
So what I'd recommend and what we do, you can do walking epidurals, but really there's really no benefit if you look at the studies to walking with an epidural. I try and tell parents or mom that if you want to walk, just walk all you want before the epidural, and then when you decide you want it, then we'll put it in.
There's a question about, and we asked if anyone's using remifentanil, but is there any community practice that uses remifentanil for labor analgesia? So a few hands. So one of the follow-up questions is monitoring for that. So respiratory monitoring, do you use capnography, pulse oximetry while a patient's receiving remifentanil? There was a sub-analysis study I was involved in, like 20-odd% of women get an apneic episode when on remifentanil. So do you monitor for that?
Both at UCSF and one's used at Utah. I think the key is really the one-on-one supervision with someone always present and using the human as the respiratory monitor of the patient. We did not use end-tidal CO2. I know it is used successfully at some institutions, but it has its own limitations, falling off, giving false readings, and so on like that. But having said that, I don't think it would be a bad idea, just as long as you know its limitations. And I am an advocate also for continuous pulse oximetry.
Okay, I'm going to punish Manny for bringing it up, but you mentioned tachyphylaxis.
Yes.
What is it really? Does it really exist? Is it something theoretical? Is it actually, what's the mechanism behind it?
Well, it's described in the literature, and how I describe it, and what kills me is when I'm on call at night and you bolus with lidocaine, and the epidural's really not working. So at least how I try and explain it to the residents is if you bolus like 2% lidocaine or 1.5 or whatever, and they're complaining of a lot of pain, you might get relief for like maybe an hour and a half, but then the next time you dose with lidocaine, guess what happens? You only get like an hour out of it. Then you bolus again, and then you only get like 45 minutes. So to me, that's tachyphylaxis.
So there's a question about block failure, a lot of it being the progress of labor, so just trying to play catch up. So in line with that, and Manny can pipe in, and as can Ed, do we have adequate pumps to handle this? Should we have 2-channel pumps with different concentrations for second stage of labor or later on?
I would say no. I think 1 pump is plenty. And like I said, we're only intervening now with the PIB pump. We're down to 12% of the time that we're giving an extra bolus. And not all of those are in the second stage. So I think it's okay to see some patients. I know you don't like to, Brendan, but you know, it's actually worthwhile going in the room once in a while. And so I think we can just, you know, bolus manually in the instances where labor is really severe and they need some extra analgesia.
Other comments? As an aside, the Giorgio Campagna study that Ed mentioned did have 2 different channels. For the PCA, it was a more concentrated solution, and the PIB did a better job in minimizing that. Therefore, the group that didn't get PIB got more concentrated solution, more motor block, and therefore more instrumental delivery. So you might take away one problem of pain and introduce more assisted deliveries.
Well, that was the whole point of that one. The part of the meta-analysis where the people who actually had the PCA pump, even just having the PCA probably leads to more of a motor block. And
So an interesting question. I do regional anesthesia as well, and we're very concerned of redoing a block if you have a lot of local anesthetic around nervous tissue you've just blocked. Is the same concern expressed when you're replacing a block? So you've already had a lot of local anesthetic and you're going in a second time. Any concern, any theoretical concern?
okay. Yeah, I guess if you've dosed up someone for surgery, for an epidural, for a C-section, and that isn't an adequate block, I'm not so much concerned about giving more local anesthetic in the epidural space and causing nerve damage as much as if you're reaching pretty toxic doses at that point. So at that point, you really do want to do a spinal. However, if you follow that up with a spinal, the risk of having a total spinal after dosing up an epidural is very high. Like, I'm not sure exactly what the numbers are, but we've always quoted about 10% based on some old studies. So I'm a real firm believer when you have a failed epidural that you've dosed up for a cesarean delivery, that you follow that up with a CSE and you give a small dose. I've given as small as like 2 to 3 milligrams of bupivacaine just to spiff up a block that wasn't adequate, but then just that small amount does a great job. But sometimes you might have to give more. You have to look at the block that you have and what kind of effect you're having at that point. But that's a really safe way to give the woman an adequate block for surgery. And if you need to give a little bit more through the epidural catheter, you still have the epidural catheter to spiff up that spinal. So that's how Brendan and I consistently deal with the failed epidural that you've dosed up.
You definitely can get a high spinal. I've been involved in several of them, so you just be careful, and it was a good technique what Ed just said.
I would like to say that long ago I convinced everybody in our group to just do a study where we were going to do spinal anesthesia for everybody. Just pull out the epidural catheter and just do a spinal before you've dosed up the epidural and see if we could be faster, because I get kind of impatient with sometimes how long the epidurals take to come on. And just before we did the study, I did it one night, and of course gave the woman a total spinal. So we didn't do the study.
So there's actually 3 questions asking how you manage this, where you have an adequate block height by sensory testing, but pain either at C-section or pain during labor.
So if they have
What's
to.
your techniques? So adequate sensory level to
Yeah.
whatever, but
So the thing is well, it depends, provided that you have a good, adequate fetal heart rate, and it's not like a stat, and you don't have to worry about it. So you check a level, and hopefully it's okay, and you've got a good T10 level, and everything's good. As long as they don't make incision, you've kept all your options. So if you don't have an adequate sensory level, then you can do whatever. You could do an epidural, you could do a spinal, you could do a CSE. You have your options. But once they make that incision, then that's when you run into problems. Sometimes I've seen some, and maybe the panel could say this, where they'll just make an incision and they complain of pain, but if you use like local anesthetic and then they go deeper, there's no problem. So I've been involved in those type of things. But if they're continually have pain after the incision, obviously you're going to have to do a cesarean section.
So a question from Mark. Nitrous oxide plus epidural? Nitrous oxide plus remifentanil? Nitrous oxide plus
the short answer
remifentanil
is
plus
no,
epidural?
but let me give you some background on why. So, the way I look at it is if you have an epidural and it's functioning, you don't need nitrous oxide. And so that was sort of one of the rules on the protocol, is that, if an epidural is running, you shouldn't be giving nitrous oxide, and you would want to know about that, and you would think more about replacing the epidural rather than limping a bad epidural along with nitrous oxide. The second one, mixing nitrous and remifentanil, I would just say no. There's an incredible amount of vigilance that needs to go along with remifentanil, PCA, and I would not be adding nitrous to the mix.
You can get a synergistic effect, so you need to be careful. And then instead of just like mild sedation, you're basically moving into moderate sedation with when you're mixing.
General anesthesia.
Or general anesthesia when you're doing
a nitrous narcotic anesthetic.
Yeah. So I also want to mention too that there's plenty of studies where they've used nitrous oxide to place IV catheters like in an emergency room. So that's another option you could do. If they need an IV in a labor and delivery floor, you can use nitrous oxide. And there's even a mention of possibly using nitrous oxide for someone that has a difficult for labor epidural insertion. They're flipping out and they can't stand. So you give them a little nitrous while you place your labor epidural.
Yeah, we do that. I want to be clear that, as long as the epidural hasn't been dosed for the placement, that's reasonable, as long as they can, coordinate their position while they're breathing the nitrous.
There's a question about, we talk about low dose epidural. What is low dose? What do you use? I guess I could ask the panel, what does each person use in terms of concentration of bupivacaine or ropivacaine?
Well, yeah, in the slide I kind of put up the fact that, the low dose for us is 16th percent bupivacaine with you have to have a narcotic, either fentanyl or sufentanil with that for that to work. And that's running at about anywhere from 10 to 12 mils a minute. Or ropivacaine, probably less motor blocking, and so probably equivalent would be like 10th or 12th percent ropivacaine. 10th percent's easier. And again, you have to have narcotic with it.
I consider 12% or 16th dilute or low dose, but from the studies, you'll be able to quote maybe better, but I think sometimes they use even 10th percent or somewhere around there and still will consider it low dose.
10th percent is the most concentrated that you would consider a light epidural, and that's bupivacaine. 10th percent bupivacaine, and 10th percent ropivacaine, I think most people would consider that a light block, but 16th percent works really well, and as long as you have adequate either fentanyl or sufentanil with it.
So it's Stanford 0.0625%.
Yeah.
And we did a meta-analysis looking at studies with low and high, and 0.1 and below versus greater had more assisted deliveries, longer labor, without any analgesic benefit. But that was primarily driven, that meta-analysis, by the COMET study, which Ed spoke about. So how much extra benefit you going lower and lower and lower? There obviously is a break-even point, and you have to add more and more opioid, and then you're getting more of an opioid effect. But you can go as low as 0.0625% without, and some have gone even lower, 0.05. So.
We're really reaching the point with 16%, at least at our institution, that we can't really increase our spontaneous vaginal delivery rate much more. I mean, it just becomes, we were at 94% in that study. So, I mean, you can't really improve on that.
Yeah. But all the bolusing techniques per PCEA are optimized by using large volume. So you must go dilute before you even consider bolusing techniques. Do you consult your patients and tell them of your block failure rate, expected block failure rate, when you are going to do an epidural? Is that part of your consultation process? Do you quote them a figure, like Ed, 90 or 100%?
I do. I usually quote about a 15% failure rate. We're not quite that bad, but I just like to set the expectation so that if we do need to replace it, there's no hard feelings.
So something interesting, when I'll usually get a mom that's a and she'd come back, she had an epidural before, and goes, oh, you placed my labor epidural. And I said, did everything go okay? And if she says yes, and it's yes, I definitely did it. And if it didn't go well, no, you're confusing me with somebody else.
I'd like to, the one thing, comment I'd like to make about that is I really like to use it as a time to educate your patients. We always talk about the consent part, and I really wouldn't even call it consent anymore. I just, I'm going to inform my patients and educate them and set their expectations, like Mark said. I asked one of the people that works on the closed claims analysis, what percentage of medical legal claims were settled based on consent for anesthesia? And the answer is 0. So you don't have to make it a medical legal discussion that you're having with people, but educate them. And I think educating them about, I don't give them a percentage. I say sometimes the blocks fail and we have to replace it. Actually, I do say 1 out of 20 times or so. And then I also warn them about fetal bradycardia, so that if that does happen, they aren't freaked out by it. So I think the thing to do is to warn them about the things that can happen and that they're prepared for, not in a legal way, but just educating them.
Another thing I tell people too is, even when we place the labor epidural, we're here 24 hours a day. If you need anything, just call us and we'll come help you. So a lot of times that helps too.
Mark, a question for you. Remifentanil and hyperalgesia, an issue when you're using it for labor analgesia? Theoretical?
Well, it's sort of interesting. So what we do commonly see is, as you progress through labor, and especially as you go from the first to the second stage with remifentanil, you typically do need to go up in the amount that you need. I know that's not quite the questions that's being asked, but as to the exact reason why, I mean, sure, it could be that the pain's increasing or the fatigue's increasing or so on like that, but the flip side is, there has been some thought that there's sort of a acute tolerance almost being developed to it. And I think probably a more clinically relevant point is that you just need to frequently assess the patient, make sure that the dose you have is adequate, and if not, adjust it appropriately.
Question for Manny. Now that we have Sugamadex, should ROC Sugamadex be the preferred? You mentioned sucks.
Yeah, you can definitely give Sugamadex afterwards if you're worried about extubation. And so, yeah, absolutely. We use it a lot, and yeah.
If I can ask the panel's technique, what is your preferred? Do you still use sucks, or do you use ROC with Sugamadex?
We still use sucks.
I've never used Sugamadex, or rocuronium for a rapid sequence induction yet for a C-section.
Yeah. I don't either. We do it so infrequently, general anesthesia. But interesting, there was a study showing longer time to desaturation because less fasciculations, they theorized, with rocuronium versus sucks. So maybe there could be an actual advantage. We're running over. I feel bad for the poor vendors. So can we end it there? And thank you very much for the panelists, and see you after the break.